Welcome everyone. Let's talk about burn. All thermal injuries, hot or cold, require the identification and management of the associated mechanical injuries like fractures and also bleedings. So you have to maintain the normal hemodynamic and good volume resuscitation. So what are the types of thermal injury? It's either burn by hot or by cold injuries. Let's come to the burn injury. So what's your priority in burn injury is airway, breathing, circulation, disability, and of course you have to stop the burning process in the first instance and then assess the patient as ABCD. The first priority is airway. So usually consider inhalation injury, especially if the burn happened in a confined space. Establish and maintain patent airway early and consider early endotracheal intubation. So if the patient have signs of airway problem, of airway burden, you have to intubate the patient as early as possible, prematurely. Oxygenate and ventilate. Give oxygen if necessary. Ventilate the patient if the patient have no breathing or decreased breathing. Obtain ABG and CO levels in order to consider exact oxygenation and also to know whether there is CO poisoning or not. How do I identify an inhalation injury, an injury to the airway and also to the respiratory tract? So first, by listening to the sound the patient is having, hoarseness of voice or stridor, signs of upper airway obstruction. Hypoxia, inflamed oropharynx if you look at the oropharynx. History of closed space. And the patient says that the burn happened in a confined and closed space and all the inhalation I have inhaled. Carbonaceous sputum. And also carboxyhemolysis, if you measure it, especially on ABG machine, more than 10%. Although they say in non-smoker people more than 5% is significant, more than 10% in smoker people is significant. Sinking of hair, eyebrows, and eyelashes that's happening in this patient. Then coming to the circulation, you have to maintain organ perfusion. How is that? By putting an adequate IV access. You can put an IV cannula in the burnt area if necessary, but beware of when there is edema, the IV may be pulling out in the veins. Monitor the vital signs of the patient. Hourly urine output. The best measure to measure the perfusion of the patients with burn is urine output. For an adult, it should be 0.5 ml per kg per hour. In children, 1 ml per kg per hour. How do I estimate the burn size? We have a rule of 9. So 9%, 9% in anterior and posterior, and I mean the chest and abdomen. Then anterior and posterior, each one is 9 in the leg. Upper arm is 9%, anterior 4.5, posterior 4.5. Also the head totally is 9% and genitalia is 1%. So if you cannot define, if you have to estimate by the hand of the patient. So the hand of the patient is including the fingers equals to 1%. In children, it has a different estimation. So because their head is larger, 9 and 9 equals to 18%, and legs are 7%. To assess the patient, you have to know the type of the burn, whether it is first degree or second. So we have 3 degrees: first, second, and third degree. The first degree is called superficial. In the superficial one, it is just there is redness and pain, as if the skin has exposed to sun. In the second degree, it is called partial. We have again superficial and we have deep deep partial thickness burns. And in third degree, we have third degree burn, also call it full thickness burn. In partial thickness burn, again, we say it's superficial and deep. Usually in superficial one, there is some perfusion to the skin. If you press it, there will be a regaining of the perfusion. But in the deep one, usually the patient is having no good perfusion and usually less painful. Again, in partial thickness burn, there is usually redness and pain plus blistering formation. While in the full thickness burn, the skin become leathery, and it might be black, it might be white, but usually it is painless because all the surface, all the nerves involved. So, what is the rate and type of fluid administered to patients of burn? You have to know that this is the last ATLS guideline. It says that if there is flame or scald in adult patients, it should be 2 ml per kg per total body surface area of Ringer's lactate. Of course, you have to only include partial and full thickness burn. Do not include superficial burns. So 2 ml per kg per total, but this is called Parkland formula. Previously, in the previous years, it was 4 ml per kg. Then they said 2 to 4. Nowadays they say 2 ml per kg. As we said, the best adequate fluid calculation is to measure the urine output after that. Your target is 0.5 ml per kg per hour or 50 ml per liter per hour. In children, it is 3 ml per kg. But if the children is very young and less than 30, you have to also add a sugar-containing solution. Example, you give Ringer lactate plus glucose water or glucose saline. The target in children is 1 ml per kg per hour. If there is electrical injury in any age, because electrical injury exposes the patient to damage of the muscles and myoglobinuria, you have to start with this dose, 4 ml of Ringer lactate per kg per total body surface area until the urine clears. The urine output should be 1 to 1.5 ml per kg per hour. What we calculate, so the calculated fluid, half of it should be given in the first 8 hours and the other half should be given in the next 16 hours. So this should be given in 24 hours. And you have to know that you have to estimate the time of the burn. For example, if a patient delayed presentation after 3 hours, you give this over 5 hours if because you have to measure from the time of the burn. No. Other informations that you take is ample history. So take care about whether the patient is having any allergies because you are giving medications, past medical histories, and if the patient is pregnant or not, last meal, and also the environment that happened, the area and how it happened, whether the patient jumped from a building and then fractured all his bones, or also developed any internal bleeding. So not sometimes the burn is not the only issue. Tetanus status, you have to consider giving tetanus to any patient who is having burn, especially if the child more than 10 years and above. Other management is baseline blood analysis, example, blood gas analysis, and doing chest x-ray, gastric tube insertion if the patient is repeatedly vomiting, analgesia, especially you have to give IV narcotic like tramal, pethidine, and also morphine. You can also give simple things like paracetamol, but usually the burden having severe pain Wound care is very important to. So usually, partial thickness burns are painful when air currents pass over the burned surface. So gently covering the burn with a clean sheet decreases the pain and deflects the air currents. So, for example, when some people they use cling films that they cover the food. They use it to cover the food. Remove any previously applied medication. So do not break or blister any blisters because it may expose the patient to infection. Sometimes some people give also pain management directly on the skin, like they give lidocaine solution, lidocaine creams as a pre-hospital. Also antibiotic like flamazine. Flamazine sometimes giving to the patient is as an local antibiotic. So you have to wash the area, but not with the cold water, because it may lead to increase in the extent of the burn and may lead to hypothermia. Usually a fresh burn is a clean area. It should be protected from contamination. When necessary, clean a dirty wound with a sterile saline. Ensure that all individuals who come to contact with the wound should wear gloves and gown, and minimize the number of caregivers to the patient. You have to protect the environment of the patient. A documentation of all what have you done is important. A patient is with chemical burn, you have to flush with copious amounts of water for 20 to 30 minutes, whether to the skin or to the eye or to the mucous membrane. If there is a powder, you have to brush off the powder, then flushing it. About electrical injury, usually when there is electrical injury, there will be fascia, muscle damage, subcutaneous tissue, even bone damage. Sometimes there might be the very trivial injury, very trivial burn surface, but when inside there is a lot of tissue damage. Sometimes there might be destruction of the tissues leading to release of myoglobin, which obstructs the tubules of the kidney, leading to kidney failure. That's why you have to increase the fluid that you give to 4 ml per kg per total body surface area. And the urine output, as we said, should be 1 to 1.5 ml per kg per hour. Maintain adequate perfusion to the patient with patients of electrical burn. The transfer criteria should be the hospitals should have a criteria between themselves, but usually which patient do you transfer to a burn surface area, to burn center? Any partial thickness, it means second degree, or full thickness burn more than 10%. Of course, any full thickness burn should be seen by burn center. Also, sometime any size of the burn, but the burn including face, eyes, ears, hands, feet, genitalia, perineum, skin overlying major joints, because it may lead to contracture later on. Also, significant electrical burn, including the lightning injury, which has high mortality rate. Significant chemical burns, inhalation injury, and if the patient have pre-existing illnesses that could complicate treatment. For example, if the patient is immunocompromised or diabetic, associated injuries may need care in a trauma center before transfer to a burn center. So you have to be careful to find any associated fractures and bleedings. Coordinate with the burn center physician. Tell them that I will send the patient. So send them the documentations, the information, and also the laboratory results that you have done. Coming to cold injuries, how does cold affect the patient? By the degree of the temperature, duration the patient remained in that cold environment, the environment condition, whether it is whether the environmental condition was wet or dry, it was the windy or not. Immobilization of the patient remained for how long in that area, moisture, and also vascular disease. If the patient having already peripheral vascular disease and cold might lead to vasoconstriction, leading to more damage. And also open wounds, which is a good area for entry of infection. How do I recognize a local cold injury? Of course, you have different terminology. Usually in our area in Iraq and Kurdistan, it is rare, but we have first one which is called frost nip. This is frost nip, in which there will be pain, coldness, and usually the skin becomes red in color and purple in color. Then if the patient remain in that condition, they develop frostbite. Frostbite have a superficial and deep one. Usually in the superficial, because of vasoconstriction and remaining of the crystals in the micro vesicles, it will lead to pallor. It's very painful. There is pins and needles sensation. Then if progress, it may lead to irreversible damage, in which the skin becomes black, hard, and numb. Although with good treatment, many of them, they may return to normal. So this is a frostbite. The superficial frostbite. This is deep frostbite. It leads to darkness and hardness of the skin. We have non-freezing injury, in which the patient remains in just above freezing temperature 1 to 15 in a plus wet environment. So this is leading to damage of many tissues, but usually the prognosis is very good if treated early. How do I treat a local cold injury? Decrease the duration of tissue freezing, remove any damp clothing or constricting one, and replace it with a warm blanket. Place the injured body part in a circulating water with a constant temperature of about 40 degrees centigrade until pink color and perfusion return. Of course, it should be wet, rewarming. Please avoid dry heat. Avoid dry, and also do not rub or massage the area, because it may lead to more tissue damage. And also rewarming can be extremely painful, so you have to provide adequate analgesia by intravenous route. So the summary is that for burn injury, recognize and treat inhalation injury, very necessary. Provide a good fluid resuscitation with Parkland, and early identification of the other injuries should be done, and which patient you have to transfer to the burn center. Cold injuries, local and cold injuries should be treated with moist heat and systemic analgesia. Thank you.